Welcome back to the deep dive. Today, we're tackling something really important, hypertension, high blood pressure.
It's incredibly common.
And often people have no idea they have it, right? It doesn't really show symptoms.
Exactly. Which makes understanding it, super crucial.
So for this deep dive, we're using some MSRA revision notes as our guide.
That's right. We're aiming to pull out the absolute must-know info, stuff that's easy to remember, particularly if you've got exams on the horizon.
Perfect. Consider this your high-yield summary. If you need to get up to speed on hypertension, you are definitely in the right place.
Let's jump in.
Okay, so first things first, what is hypertension officially?
So, put simply, it's when your arterial blood pressure is persistently high. And that word persistently is really important.
Not just a one-off high reading.
Precisely. And like you said, usually no symptoms. The diagnostic criteria in a clinic setting are a systolic pressure of 140 mmHg or more, or diastolic pressure of 90 mmHg or more.
140 over 90.
Yep, 140 over 90. And that needs to be seen on at least 3 separate occasions.
3 times.
Okay.
And we usually think of normal as being around 120 over 80.
Around that, yes. 12 to 80 is a good general target, but, blood pressure isn't static. It changes with age, time of day, stress, whether you've just run up the stairs.
Sure.
And it varies person to person. It actually follows a normal distribution of the population, so picking one single cutoff is, it's a practical choice.
That makes sense. So multiple readings are key.
Absolutely.
Oh.
Ideally, in both arms, and critically, with the right cuff size. A cuff that's too small can give you a falsely high reading.
Ah, good point. So if someone does have high readings in the clinic, how do you confirm it's really hypertension?
Great question. If the clinic reading is high, say over that 1490 mark, we typically move to either ambulatory blood pressure monitoring, that's ABPM.
Where you wear the cuff for 24 hours.
Exactly. Or home blood pressure monitoring, HBPM, where you take your own readings over several days. And interestingly, the diagnostic thresholds for ABPM or HBPM is actually a bit lower. 135 over 85 mmHg on average.
Lower? Why is that?
Well, it reflects your real-world blood pressure, away from the potential stress of the clinic. The white coat effect.
Right. White coat hypertension. People get nervous.
They do. So NICE guidelines actually recommend monitoring over time in these cases, rather than rushing into treatment based on just clinic readings. You get a much better picture.
Makes sense. Okay, so let's say it's confirmed. How is hypertension classified? Are there different levels?
Yes. The British Hypertension Society uses a pretty clear staging system. Stage 1 is a clinic BP over 140/90, or an average ABPM HBPM over 135/85.
Okay, stage 1.
Stage 2 is the next step up. Clinic BP over 160/100, or an ADPM HBPM average over 195.
Higher numbers.
Yep. Then there's severe hypertension, where the clinic reading is consistently over 1/8 or 1'10".
Wow, okay.
Think of it like steps on a staircase 1, 2, then severe at the top.
And I've heard of malignant hypertension. Is that different?
Very different and much more serious. Malignant hypertension isn't just about the numbers. Although they are very high, usually over 180 or 110, sometimes even quoted as over 2,000, 130. The key thing is evidence of end organ damage.
Damage to organs, like what?
Typically, the IMS, you might see things like papilloedema, which is swelling of the optic nerve head. It's a true medical emergency.
Okay, so malignant means high BP plus organ damage. Emergency. Got it. What about ISH?
Isolated systolic hypertension. That's when only the top number, the systolic pressure, is high, so over 140, but the bottom number, diastolic, is normal, less than 90.
And who gets that?
It's quite common in older adults.
Yeah.
As we age, our arteries tend to stiffen up, become less elastic, which pushes the systolic pressure up.
Right. Makes sense. So quick recap. Stages 1, 2, severe based on numbers. Malignant is an emergency with organ damage, and ISH is just the top number high, often in the elderly.
You've got it.
Let's move on to causes. What actually leads to high blood pressure?
We divide into 2 main types: primary or essential hypertension and secondary hypertension.
Yeah.
Primary or essential hypertension is by far the most common, like 90–95% of cases.
And what causes that?
That's something we don't know the single exact cause. It seems to be multifactorial, a mix of genetic predisposition and environmental factors.
Like age, diet.
Exactly. Age, being overweight or obese, eating too much salt, not enough exercise, maybe stress. It's a combination of things that gradually pushes the pressure up over years.
Okay, so that's most cases. What about the other 5–10%? Secondary hypertension.
Right. Secondary hypertension means the high blood pressure is caused by another specific identifiable medical condition. And this is important because if you can treat the underlying cause,
You might fix the hypertension?
potentially, yes, or at least manage it much better.
So what are these underlying causes?
There's a useful mnemonic to help remember some key ones. PANFRIED, or, whatever mnemonic works for you. But PANFRIED covers a good range.
PANFRIED. Okay, break it down for us.
Sure. P is for pregnancy-related issues like pre-eclampsia. A is for aortic coarctation. That's a narrowing of the aorta. Look for radiofemoral delay.
Pulse delay between arms and legs.
And it's for NSAIDs and other medications. Steroids, the contraceptive pill, some decongestants. They can all raise BP.
And common meds.
F is for fetal factors. Things like low birth weight have been linked. R is for renal disease. This is actually the most common cause of secondary hypertension.
Kidney problems? Like what specifically?
Oh, glomerulonephritis, pyelonephritis, polycystic kidney disease, diabetic kidney disease, and importantly, renovascular disease, especially renal artery stenosis narrowing of the arteries supplying the kidneys. That's often the most common curable cause.
Okay. R for renal. What's next?
I is for insulin resistance or metabolic syndrome. E is for endocrine disorders.
Bertons.
Yep. Things like Cushing syndrome, Conn syndrome, which often presents with low potassium, by the way.
Good tip.
Pheochromocytoma, that's a rare adrenal tumor, causing surges of adrenaline, classically giving palpitations, sweating, headache. Also acromegaly, thyroid problems, diabetes.
Lots under E and D.
D is for diet, especially high salt intake, though that overlaps with primary causes too. So PANFRIED covers a lot of ground.
PANFRIED, pregnancy, aorta, NSAIDs meds, fetal, renal, insulin resistance, endocrine, diet. That's really helpful. So related to causes, what are the general risk factors we should be aware of?
Yeah, there's definite overlap. When taking a history, you're looking for things like age risk increases as you get older. Gender men tend to have higher rates than women, at least until menopause. Ethnicity is important too.
How so?
People of Afro-Caribbean descent have a higher incidence and often develop it earlier.
Okay. What else?
Weight is a huge factor. Obesity significantly increases risk. Lifestyle choices like smoking, excessive alcohol consumption, a diet high in salt or sugar, and being sedentary are all big ones.
The usual suspects for lifestyle.
Pretty much. And then other medical conditions play a role: diabetes, high uric acid levels or gout, a family history of hypertension, and obstructive sleep apnea.
Right. Lots to consider. Now, can we dig into the how? What's actually happening physiologically? The pathophysiology.
Sure. The fundamental equation to remember is blood pressure equals cardiac output times total peripheral resistance. BP equals COX DPR.
Okay, cardiac output times total peripheral resistance.
Cardiac output is how much blood your heart pumps out per minute. That's stroke, volume times heart rate. Total peripheral resistance is basically the resistance the blood meets as it flows through the small arteries, the arterioles.
So it's about flow and resistance.
Exactly. In most long-standing hypertension, the main problem seems to be an increase in total peripheral resistance. The arterioles are constricted or changed somehow, making it harder for blood to flow through.
Like trying to push water through a narrower hose.
Perfect analogy. Yeah. The pressure has to go up to maintain flow. Though in some younger people, initially it might be a high cardiac output driving the pressure up, but increased resistance is more typical long-term.
Anything else contributing?
Reduced vascular compliance, basically. Stiffer arteries, like we mentioned with ISH, also plays a part. And complex systems like the renin-angiotensin-aldosterone system, our AAS, and the autonomic nervous system are heavily involved in regulating all this. But the core is often that increased resistance.
Got it. So if it's usually asymptomatic, how does it actually present? What signs or symptoms might occur?
Yeah, the silent killer reputation is well-earned. Most people feel absolutely fine. Some might mention things like headaches or dizziness, but these are really non-specific and not reliable for diagnosis.
So we rely on measurement.
Primarily, yes. But during an examination, a doctor is looking for signs. Obviously, the elevated BP reading itself, but also signs of end organ effects or secondary causes.
Like what?
Looking in the eyes, fundoscopy for hypertensive retinopathy, those changes in the blood vessels. Listening over the abdomen for renal brutes, which might suggest renal artery stenosis. Checking pulses that radiofemoral delay for coarctation. Feeling the heartbeat's position a displaced apex beat could suggest the left ventricle has thickened, LVH.
Okay. And are there any red flags that scream urgent problem?
Definitely. For malignant hypertension, red flags would be things like sudden visual disturbances, severe headache, nausea and vomiting, chest pain, confusion, or even seizures. Finding papilloedema on fundoscopy is a major red flag.
And what about symptoms suggesting those secondary causes from PANFRIED?
Good point. If someone has kidney disease, they might have hematuria, blood in urine, edema, swelling, or flank pain. For endocrine causes, think about the specific conditions, that classic triad for pheochromocytoma, palpitation, sweating, headache, muscle weakness and low potassium for cons, features of Cushing's or acromegaly, symptoms of thyroid problems.
And for coarctation.
You might hear about cold legs, pain on walking, claudication, nosebleeds, and again, that radiofemoral delay on examination is key.
You mentioned fundoscopy and retinopathy. Can you expand on that? The Keith Wagner grades.
Sure, fundoscopy is crucial. The Keith Wagner classification grades the severity of damage to the retinal blood vessels. Grade 1 is mild narrowing. Grade 2 shows more definite narrowing and AV nipping, where arteries compress veins. Grade 3 adds retinal hemorrhages, exudates, cotton wool spots. Grade 4 includes all of that, plus papilloedema, the swelling of the optic disc. And Grade 4 signifies malignant hypertension.
So worsening changes in the eye mirror the severity. Grade 4 is malignant. Very clear. Okay, let's talk investigations. If you suspect hypertension, what tests are typically run?
The goals are threefold. Confirm the diagnosis, assess overall cardiovascular risk, including looking for secondary causes, and check for any end organ damage already present.
Right.
So you start with a focused history and clinical examination. Accurate manual blood pressure measurement is obviously fundamental. Urinalysis, just a simple urine dipstick, is essential, and ECG, and fundoscopy. Those are basics.
And to confirm the diagnosis if clinic readings are high.
That's where ABPM or HBPM comes in, as we discussed. That's really the gold standard now, unless the BP is already severely elevated.
Okay. What about blood tests?
Standard bloods would include a full blood count, FBC, urea and electrolytes, UNEs, paying attention to potassium for cons, and kidney function, EGFR. Blood glucose to check for diabetes, and a lipid profile for cholesterol.
And the ECG. What might that show?
It might be normal, but you're looking for signs of left ventricular hypertrophy, LVH, the heart muscle getting thicker due to the increased workload. There are specific criteria like the Sokolow-Lyon criteria. You might also see non-specific changes.
And an echo?
An echocardiogram gives a much better assessment of LVH and overall heart function. It's not always routine initially, but very useful.
What about the urine test beyond the dipstick?
You'd look for proteinuria, protein in the urine, or hematuria blood. Often, an albumin-creatinine ratio, ACR, is done to quantify protein leak, which is an early sign of kidney damage.
And if you suspect one of those secondary causes?
Then you tailor investigations. Based on clinical suspicion, you might order tests like plasma renin and aldosterone levels for cons, a dexamethasone suppression test for Cushing's, urinary metanephrines for FAO, autoantibodies, thyroid function test, maybe renal ultrasound or other imaging of kidneys, adrenals, or pituitary gland, sometimes even a renal biopsy.
So the basic workup, then targeted tests if needed. You mentioned accurate BP measurement. What are common mistakes there?
Oh, loads. Using the wrong cuff size is a big one. Too small reads high, too large reads low. Not having the arm supported at heart level. Talking during the measurement. Not letting the person rest quietly for a few minutes beforehand, only taking one reading instead of averaging 2 or 3.
All things that can throw off the result. Good to remember. Okay, diagnosis confirmed. How is hypertension managed?
Right, management. First, unless it's severe hypertension, you always confirm with ABPM or HBPM before starting lifelong medication.
Makes sense. What comes first? Lifestyle.
Absolutely. Lifestyle modification is cornerstone therapy for everyone with hypertension. That means advice on diet-reducing salt is key, but also thinking about overall healthy eating patterns like DISH, regular exercise, weight loss if overweight or obese, limiting alcohol and caffeine intake, stopping smoking.
These can make a real difference.
A significant difference, yes. Sometimes enough to control mild hypertension on their own, or reduce the amount of medication needed.
Okay, but often medication is needed. How is that decided?
We generally follow a stepwise approach, largely based on the NSAID guidelines in the UK. The choice of the first drug depends mainly on age and ethnicity.
Okay, talk us through the steps.
So step 1, if you're under 55 and not of Black African or Afro-Caribbean family origin, you typically start with an ACE inhibitor like Ramipril or an ARB like losartan if ACE inhibitors aren't tolerated, often due to cough.
And if you're over 55 or of Black African Afro-Caribbean origin?
Then you'd usually start with a calcium channel blocker, CCB, like amlodipine.
Okay, that's step 1. What if that's not enough?
Step 2, you combine drugs. Usually it's the ACE inhibitor or ARB plus either a CCB or a thiazide-like diuretic, such as indapamide.
So 2 drugs in step 3.
Step 3 is triple therapy, ACE inhibitor or ARD plus a CCB plus a thiazide-like diuretic.
All 3 together. What if even that doesn't work?
That's called resistant hypertension. Step 4 requires specialist advice. Options include adding low-dose spironolactone, another type of diuretic, or possibly an alpha blocker or a beta blocker, depending on the individual.
Got it. Are there specific BP targets to aim for?
Yes, for people under 80, the target is generally below 140/90 mmHg in clinic, or below 14008 PMHb PMHd on ABPM HBPM. For people aged 80 and over, the target is slightly higher, below 145/8 clinic or below 145/85 ABPM HBPM.
Slightly less aggressive targets for older patients.
Generally, yes, it's about balancing benefits and risks. You mentioned drug side effects. Any key ones to recall?
Good point for exams. ACE inhibitors are famous for causing a dry cough. ARBs are less likely to do that. CCBs, especially amlodipine, can cause ankle swelling. Thiazide diuretics can affect electrolytes like potassium and sodium and raise glucose and uric acid. Spironolactone can cause hypotassium and gynecomastia in men.
Excellent summary. And when do we actually start treatment? Always for stage 2 and severe.
Yes, stage 2 and severe hypertension should generally always be treated with lifestyle advice and medication. For stage 1, it depends on the person's overall cardiovascular risk. If they're under 80 and have established cardiovascular disease, kidney disease, diabetes, or a high CVD risk score, like QRS 10%, you'd treat. Even if the risk is lower, you might treat if they're younger, say under 60, because of the long-term lifetime risk. Over 80, you'd usually treat stage 1 only if their clinic BP is over 50/95.
So it's a nuanced decision for stage 1. What about managing malignant hypertension? You said it's an emergency.
It is. But you have to lower the BP cautiously. Dropping it too fast can actually cause harm, like stroke or kidney injury, because the body has adapted to the high pressure. The aim is usually a controlled reduction, maybe about 20–25% in the first hour or two. How is that done?
Often with oral agents, initially, if possible, like labetalol or nifedipine. In very severe cases, or if the person can't take oral meds, intravenous drugs like IV labetalol or sodium nitroprusside might be used in a hospital setting, usually intensive care. A key point is that GTN glycerol trinitrate is generally not used for hypertensive emergencies like this, unlike in heart attacks.
Interesting contraindication, and patient education is vital throughout.
Absolutely critical. Helping people understand why they need treatment, even if they feel well, how the drugs work, potential side effects, and the importance of sticking with it, medication compliance, is a huge challenge in hypertension.
Because they don't feel sick.
Exactly. Which brings us to the consequences if it isn't managed. What are the complications?
They're serious and widespread. Hypertension is a massive preventable risk factor for premature death and disability. It damages blood vessels throughout the body, affecting which organs mainly?
The heart, the kidneys, the brain, and the eyes.
So for the heart.
It leads to left ventricular hypertrophy, LVH, increases the risk of coronary artery disease, heart attacks, angina, heart failure, arrhythmias like atrial fibrillation, peripheral vascular disease, and even aortic dissection.
And the kidneys.
Damage can lead to proteinuria, chronic kidney disease, CKD, what we call hypertensive nephropathy, and eventually end-stage renal failure, requiring dialysis or transplant.
The brain.
Big one here is stroke, both ischemic, clot, and hemorrhagic bleed. Also transient ischemic attacks, TIAs or mini strokes, vascular dementia, and hypertensive encephalopathy in very severe cases.
And the eyes? We mentioned retinopathy.
Yes, the hemorrhages, exudates, AV nipping, and papilloedema. All consequences of that sustained high-pressure damaging delicate blood vessels.
So it really affects the whole system. Uncontrolled hypertension is seriously bad news.
Underlines why identification and effective management are so incredibly important.
Okay, let's try and wrap this up. What are the absolute key takeaways from our deep dive today?
I'd say hypertension is common, often silent, but potentially devastating. Diagnosis needs care. Think clinic versus ABPM, HBPM thresholds. Remember the stages 1, 2, severe, malignant. Understand the difference between primary, most common, multifactorial, and secondary causes, and that PANFRIED mnemonic can really help there.
PANFRIED, yeah.
And management involves lifestyle first, then a stepwise approach to medication, usually following nice guidelines based on age and ethnicity, aiming for specific targets. And don't forget the complications: heart, brain, kidneys, eyes.
It really drives home the importance of checking blood pressure regularly. A final thought perhaps for our listeners to take away.
Maybe think about how crucial patient communication is. Since people often feel fine, how do we best explain the risks and the importance of long-term treatment adherence? That's a constant challenge.
A really vital point. Well, if you want to solidify your knowledge on hypertension or other key topics for the MSRA, definitely check out the resources at passthemsra.com.
And there's also great free content available at freemsra.com.
Definitely worth exploring. Thanks for joining us on this deep dive, and good luck with your studies.